about kids and Lyme. Not necessarily that they present too much differently than adults, but I think they have their own little innuendos that's worthwhile knowing about and kind of be vigilant about. So, neurodevelopmental issues. These are very common with children, and essentially we look for declining in their IQ. So if somebody does, for example, neurocognitive assessment on a child, their predicted IQ is often lower than what they're testing is, and that can actually happen in adults as well. However, neurocognitive assessment in this particular situation would be helpful for school. In order to get them school help or IEPs and things like that, or if they're missing school a lot, this would be a helpful tool to have and see where their IQ is. They can have regressive behavior, which means that they don't act appropriately to their age. So I always ask, well, what do you like to do for fun? And what TV shows do you watch? What's the last movie you watched? What do you do with your friends when you're hanging out? So this has to be age-appropriate behavior. If your 15-year-old is watching Dora the Explorer, that's not right. Okay, so the other thing is there'll be separation anxiety, which is again regressive behavior. They can have baby talk. And you obviously you won't see that, if you're not interacting with them regularly, but you will see them switch back and forth between talking normally or talking like a baby. ADD and ADHD. I actually talk about this a lot, where I think that every child who's diagnosed with ADD and ADHD, it's worthwhile to check them for Lyme disease. Because their attention span is not good many times, and often taking stimulants may make things worse. It may slightly improve their concentration, but is not going to get them to the point where you think they should be. Autism. Either children who are born with autism or with autism and then all of a sudden have regression in their behavior. They become more aggressive, less manageable. These kids have to be tested because they're going off from their baseline. So autism should not be a degenerative medical problem, right? They should stay the same, or potentially with changing their diet and doing cognitive behavioral therapy, they should get better. They should not be fluctuating in their behavioral pattern on a large scale, and they should not be getting worse. And autism itself can present in Lyme patients. So you could have a normal child. I have a lot of kids who have been on the spectrum and with treatment come off the spectrum of autism. And often they will not present in a classic way, where they do make eye contact, they are able to communicate, but they're not doing that effectively, and so they will be classified as autism because we don't know what to do with them. OCD type of behavior, and this can also present around food. So often children will have rituals around food. They won't want to touch specific type of food, or won't let somebody prepare it because they think that they're contaminating their food. So a lot of their OCD behavior can be related around food and germophobia. And then learning disability. Any type of learning disability that basically when they're falling off the baseline, when you have a family who is, lawyers at a big law firm, clearly the parents are very high achievers, and then they have 3 children with learning disabilities, you start thinking, is there something going on in their environment that's contributing to this? Because their genetic makeup should make them overachievers, not having one kid be on Ritalin and another kid has a learning disability and a 4th kid is not speaking. So these are kind of the things that you need to look and see if that's an issue. And these are movement disorders, and this is so commonly, even in neurology office. This is not the child, but I have a child from Pennsylvania who's come to see me, who basically is complaining of her number 1 complaint is pain. pain in her feet. And when she came to the office, she was evaluated by CHOP and many other, big name institutions in the area, in the state. They were planning to take her out of the country in order to see, what's wrong with her. They can't control her pain. But when she comes in, she was having, and I spend, an hour and a half with my patients. So I'm not sure how long she spent with the neurologist and CHOP, but they basically said that everything's fine and she has potentially fibromyalgia or some type of neuropathy. But she was doing something similar to this on physical exam, except with her face, which is clearly a movement disorder. So these are myoclonic jerks. She can't help it. She's in a wheelchair, but I typically have the patient stand up, feet close together, arms extended out, close their eyes, palms up, and they should be able to stand relatively still, and I actually prefer them to stand still all together for a few seconds, 5 seconds, and a lot of times these kids will have like jerking movements. They're reaching for something. So this is called myoclonic jerks, and it's an abnormal movement disorder. They can have rigidity, stiffness, choreiform movements, both because of Lyme and some of these co-infections you've heard of before. Now, seizures. Anybody's concerned with seizures of your clinical presentation or their child? Okay. So seizures are tough, and I'll show you what's happening here. So who thinks this is a seizure? Nobody? Come on. So a neurologist would not diagnose this as a seizure just based on the clinical presentation. There's a couple of things that are going on. A, she's moving her eyes back and forth, which is atypical of a seizure. She's had the clonic episode after the onset, which typically happens before the onset, and then they get sick. So this is not a classic presentation of a seizure disorder. Not to say that everything's fine with this patient. I think that this patient would receive a diagnosis of pseudo seizures, meaning to say that this is all psychiatric. I don't necessarily agree with that. I don't think this was a psychiatric event, but I also don't think it was a true seizure, because a true seizure has a definition where a part of your brain, at least 6 millimeters, gets overexcited and then stops doing random activity and in turn does the same thing, and so you're not able to focus on other things, and it can have clinical manifestations of shaking, eye movement, stiffness. So there's a progression, a specific progression of a seizure. So that's a true definition. This patient most likely has some microscopic things that are less than 6 millimeters going on in her brain, causing brain inflammation that can wax and wane. So I don't think that this is purely psychiatric, but at the same time, we can't diagnose it as a true seizure either. I don't think that we have the proper terminology to explain what's happening. I don't think it's psychiatric, and I think that patients get super upset when things like that are happening, because the truth is I don't think she wants this to happen. I think that this is a struggle for her and her family, but she can't help it. So I think we don't have the medical language to explain what's happening here, and the easiest thing, because it does look very similar to a seizure, is to just call it that. Sometimes these patients, this is another big thing, that they will also have true seizures. But because they have many different variations of this similar event, it often gets misconstrued and missed that they actually have true epilepsy and need to be treated with special medications to calm that down. So neuropathy, various body pains, weakness. Usually the body pain would be migratory, and the disease itself, Lyme, Bartonella, that spectrum of disorders can be waxing and waning, as you've heard before. So a patient can feel well one day, or, in terms of kids, they could be jumping up and down on the bed, and then 2 minutes later, they'll feel pain or feel fatigue, and often parents will say that they're attention-seeking, they don't want to do something because they're feeling bad if you're saying come down to dinner, or you need to do your homework, and that's when they're feeling bad, when I just saw you jumping up and down 15 minutes ago. I don't think the kids are lying. I don't think they're attention-seeking. I think this is really waxing and waning, and you need to believe your kids, because they'll stop bringing things up to you. Okay? Weakness, cranial nerve abnormalities. If you've all probably heard that Bell's palsy is the most common cranial neuropathy, where you have weakness of one side of the face that can be very subtle. I can't tell you how many kids I see in my office, everything's wrong. Even mom and dad don't notice it. But when I make them smile, one of their nasolabial folds is less pronounced than the other, and they clearly have a subtle Bell's palsy, which is part of the diagnostic criteria. And there are other cranial neuropathies, including dizziness that can be caused by cranial neuropathy, issues with swallowing that can, and voice problems, all that can be caused by cranial neuropathies. I'll talk about eyes in a minute. And they may have exercise intolerance. So in my son's school, I don't diagnose people if they don't come to me. I'm sure they have their own physicians. But I see, this was a couple of years ago, we were on a playground after school, I think it was 1 or 2 o'clock, and all of these kids from the class are running around, jumping up and down, and one of those 6-year-olds came to his mom and stands next to her and puts his head on her waist. To me, that's not normal, okay? A kid who, is running around with their friends after he's just had 5 cookies shouldn't be tired and not running around and playing ball with their peers. Or I have a child who, I ask them, well, what do you like to do for fun? Do you go out? What are your extracurricular activities? And they'll say, yeah, I do soccer, but sometimes I don't go because I feel tired. And I play a lot of video games, and we keep blaming on the society, video games, this and that. But some of these patients play video games because they can't go do soccer and they can't communicate that to their parents effectively. So they can't keep up with their peers, and that's actually one of the questions I'll ask parents or the child if they're old enough to talk. Are you able to keep up with your peers when you're running around? These are some neuropsychiatric disorders, and tics could be classified in that, or even neurologic. But tics, we talk about PANS and Pandas, which I'll touch on a little bit later. But facial tics, which are motor tics, vocal tics, they can even have complex tics. And they don't have to come on acutely. They can wax and wane, particularly when the child is not feeling well, like if they have an exposure to strep or some other virus, their tics will come on and come down when their immune system is stronger. I think you've got a lot of the neuropsychiatric presentation in terms of anxiety, depression, mania, paranoia, psychosis, thought disorders, and aggression. In the previous talk, I think aggression is a big deal because they will have rage. They don't know why it's happening, and then they'll say, "Mommy, I'm so sorry, I didn't mean that." They reprimand themselves, but they can't help it because they can't control their brain. Other issues, we've talked a lot about headaches. Insomnia, sleep disorders are a big deal, and often are actually not helped with sleep aids because they just can't shut off their brain. So they'll either won't be able to fall asleep or even wake up in the middle of the night and can't go back to bed, either because they're having some issues like urinary problems, or they just can't fall back asleep, or they've had a bad dream. That's very common. They may have vivid images and vivid nightmares, and they're really scared of it. And actually, adults have this as well. I've recently heard of a patient. He's not a child, but he's in his 30s. He's a nurse in Africa, and I think in Ghana. And apparently there they have these, I didn't even realize, they have these tent cities where they go to, if you have like these religious experiences, and you go there and like they share their religious experiences and pray to their deity, and it's like this whole religious situation. So he's a nurse who works in a hospital, and he's read one of my friend's paper, and this is the whole thing about seeing scary faces. And he's like, I've had exactly the same experience, and all these people in the tent, they all have these experiences. And he connected it and said, is it possible, because I have Bartonella, you say that you've had Bartonella when you've had this problem going on, because these symptoms went away when she was treated. Could this be that, you know, half of these people in Africa have Lyme and Bartonella? And the answer to that is yes. There's visual disturbances. I think that's an important point. Because sometimes children will tell you, oh, I don't like to read, and the mom will say, oh, they were a voracious reader, and now they don't really pick up a book. That could be cognitive issues, but it could also be anatomical problem where they have issues with tracking. And so when they scan the page, their eyes will jump, and they won't be able to concentrate on what they're reading, needing to reread the same paragraph to understand what's going on. So eye disturbances are very common, and I see that in the majority of the patients in my practice. They can have gastrointestinal issues, which is, I talk about 50% of children who come to my office, their first and number one complaint will be GI issues. So they'll have unexplained abdominal pain, nausea, vomiting. These are the typical ones. They could have diarrhea or IBS, irritable bowel syndrome, but the usual issues are we don't know why he's vomiting all the time, or he has abdominal pain and we can't explain it, and we've had the gastrointestinal workup but nothing's going on. And often it's blamed, right, because they'll take like an antibiotic for 2 weeks for the Lyme. Oh, and then when I went to my other doctor, they said it's because he's taking the antibiotic. Well, his GI issues were way worse before the antibiotic, because sometimes these infections actually live in the lining of the gut. And so they will disrupt what's the absorption, they will cause abdominal pain and nausea. GU issues, urinary symptoms, are very common, particularly in younger children, but even older, at 9 and 10, they could start bedwetting again. Kids who are potty trained. This is also very common in the autistic population. Kids who are potty trained and all of a sudden start wetting their bed again. So that's a red flag. Or somebody was telling me they went on vacation and they were in a restaurant or in like one particular area where they were hanging out for about an hour, and the child went to every single bathroom on every corner in a span of 45 minutes. So, you know, the bladder issues are actually common both in adults and with kids. And again, because the bacteria tends to live in that, it's not a very well vascularized area, and so the bacteria likes to live there because it can evade the immune system easily. Palpitations, I think some of you won the book, and cardiac issues, Dr. Spector, I mean, he talks a lot about that was basically his Achilles heel of Lyme disease. So that's worth looking into. And dizziness. So these are a couple of cases I just put together to jog your memory and kind of see if any of this applies. So this is a 21-year-old woman whose symptoms started, or girl, whose symptoms started at age 14, and her predominant symptoms, and I have a couple of patients like that in my practice actually. Predominant symptoms are psychiatric, including anxiety, psychosis, depersonalization, and seizures. I want to talk about depersonalization because people don't understand what that is, but if you have it, it's kind of freaky and uncomfortable. They feel like they're living but not in their body. Like they're looking at themselves from far away, and everything that's happening is not really happening to them. And I have more teenage kids with this complaint, but I also have a couple of adults. So she had 3 involuntary inpatient psychiatric admissions in the span of time from age 14 to 21, and she's been followed by a Harvard psychiatrist who's tried many different medication combinations on her psychiatric medication, and she continued to decline. So when she came to me, there was hyper-religiosity. She basically thought that she was a deity, and there was intrusive thoughts, severe anxiety, and severe headaches. She was diagnosed with Lyme, Bartonella Hensley, Babesia microti, and we also checked her for autoimmune encephalitis, which is when your own body is making antibodies, fighter cells against your brain, and can cause a lot of inflammation. So she tested positive for all of those things, and she started treatment a year ago, September. She was on 4 psychiatric medications at the time, and she came off all of her psych meds in the month of May of this past year, and she's back at her Ivy League school, which she wasn't able to attend for the last 3 years. She's not 100% better, she's not cured yet, but she's able to return back to her life where she was in and out of psych wards. This is a case of a 13-year-old male. This is a complicated patient. 13-year-old male with onset of joint pain and toe walking at age 2, and mom also has Lyme, so it's possible that this was passed on in utero, so he may have had this all along. But at age 9, not just joint issues and physical symptoms, he started developing problems with facial and motor tics, which were very pronounced and disruptive to him and to anybody around him, and cognitive decline, as well as regressive behavior. So for example, his specific regressive behavior could be subtle, but just letting you know. He was reading War and Peace in the waiting room, and I said, oh, are you reading this for fun? Is this for school? No, I just like it. Fine. In the exam room, he was not able to sit still from a standpoint. He was touching everything, the paintings, the stuff on my desk. He was doing this. So that's not age appropriate for a 13-year-old who was reading War and Peace 10 minutes ago. Okay, so that's regressive behavior. So he had blood work that was positive for strep, Lyme, Babesia, Duncani, and microti, Bartonella Hensley, and mycoplasma. I can't stress enough how mycoplasma is a big issue because it's walking pneumonia, and it's rarely checked for, I think, in mainstream medicine, but it can cause a lot of the same symptoms that you would think Lyme does, both actually in adults and children, but I find it more of an issue in adults, and it can cause fatigue, it can cause a lot of these neurodevelopmental issues that I just talked about. So he has 6 infections all at the same time. He was treated initially just for the infections, and things got a little bit better. His tics got better, he got better grades in school, but it wasn't enough. So then we went further and checked whether he has an autoimmune issue. Now, I am of the opinion that a lot of these infections can actually cause autoimmune diseases, which means they can cause a type of neuropathy, they can cause thyroid problems, and they can cause encephalopathy. So it's not just strep causing pandas. These other infections can cause autoimmune issues as well. Now the problem is why you don't always jump to treating, autoimmune encephalopathy of the bat is because often when you treat the infections, you can calm down your immune response enough so that patients respond well and their autoimmune symptoms subside. However, because his symptoms were so severe at onset, and he probably had these symptoms for over a decade and this infection for over a decade, he did need additional treatment, and he tested positive with the Cunningham Panel. And I don't know if do you guys know Cunningham Panel? Okay, we'll talk about it in a second. And then, as well as other antineuronal antibodies, voltage-gated potassium, GAD65, and these thyroid antibodies, thyroperoxidase and thyroglobulin, basically telling us that A, he has a zillion infections, and B, his autoimmune process is out of control. His body is attacking itself on top of the infection attacking it. So what he did better with what he did better with is a combination of treating the infections and treating the autoimmune process at the same time. And I'll touch on what I do in a little bit. So I want to touch a little bit on autoimmune encephalitis. And I did talk about it before, but for the physicians in the room, and I'm so glad to have at least one, because it's so important. It's basically involvement of the central nervous system that causes this autoimmune inflammatory response. And autoimmune responses are not new. Like we know them from thyroid, from lupus, MS. These are autoimmune disorders. This is the one that particularly causes antibodies against the brain. Why does that happen? Well, the reason why it happens, we think, in general, and this is a new field, it came on the neurology radar about 15 years ago out of Japan, because they were seeing these young women of childbearing age who basically became encephalopathic. They couldn't function, and they would admit them to the hospital, and they didn't know what was wrong with them. And then they found that they may have had teratomas, which are benign growths on the ovaries, and they would remove these ovaries. You can imagine a 21-year-old without ovaries, you know, she can't reproduce, but that was better than lying in a hospital for months. So that was kind of, we thought it was initially teratomas, and this was 15 years ago or so. Now, we think that only about 40% of these patients really have some kind of malignancy or a tumor that's contributing to these things. And most of it, we don't know what's going on. But I think a significant portion of these people actually have infections, because 90% of our DNA is actually made from bugs, because they've been here millions of years before we have. And so they've incorporated into our DNA. So when you get exposed to an infection that makes a significant portion of your DNA, you can develop an autoimmune response. Now, this is not just with Lyme. There are autoimmune neuropathies that we get after vaccines, like that H1N1 vaccine a couple of years ago. We've seen so many patients with neuropathy after their vaccinations. After flu, after various types of gastrointestinal infections can contribute to these antineuronal antibodies that attack your own brain or your own nerves. So in order to diagnose specifically autoimmune encephalitis, there's a criteria. Ultimately, it's a clinical diagnosis right now, and I'll show you why. So these people will have a decline in memory. They often have a neuropsychiatric presentation with psychosis, aggression, inappropriate sexual behavior, often being hypersexual, panic attacks, compulsive behavior, and euphoria or fear. And they can also have seizures, and they may also have some of these movement disorders that we talked about in kids. And this autoimmune encephalopathy can happen both in children and adults. So in terms of how to diagnose it, well, one would do an MRI of the head, but again, it can be non-specific or even normal. An EEG, brain SPECT or brain PET, and I'll actually go into that in a little bit more detail, which is where it looks at perfusion of the brain. So our brain is a very smart organ. If it sees that part of it is not functioning properly, it will reduce the amount of blood flow. It's not going to waste its energy on you. So it's going to perfuse you enough where you're not going to have a stroke, but it's not going to be this voracious, like, here's all the nutrients in the world. It'll, reduce the function, and will focus on parts of the brain that are actually functioning properly. which is very smart. You will do a lumbar puncture in these patients, and you can detect at times some antineuronal antibodies that you check in the blood, but you can also check it in the cerebrospinal fluid. And you could do a neurocognitive assessment and see where is that patient, and they may have visual spatial skill problems, problems with concentration, problems with memory. And back in the day, about 10-15 years ago, when people didn't know what was wrong with these patients, they would actually do brain biopsy, and that's how we know that this is actually pathologic instead of psychiatric, because these people had a change in the way their brain looked like. So it was a change in their brain matrix, and they've had lymphocytes, they had which are inflammatory cells that were present. They had a change in their glial cells, which is the supportive cells for the neurons. We don't recommend brain biopsy at this time because we have these other tools to look for, but this was definitely done in the past. And these are some of the antineuronal antibodies that are checked for, particularly the first one, the paraneoplastic panel, or the next slide that you will show, the Autoimmune Encephalitis panel, is done through Mayo Clinic and can be ordered in any lab. But I also like to use other antineuronal antibodies. I like to use the GAD65, which is in the middle of the page, potassium channel and NMDA receptor antibodies, as well as this bottom one, S100B, which is not specific to any type of autoimmune encephalitis, but really talks about that your brain is unhappy and there's brain trauma to the brain. It doesn't have to be a hit on your head that's causing these proteins to be elevated, but it could be things like infections and autoimmune processes that are elevating these proteins. I want to touch for the couple of people in the room who talk about PANS and Pandas. I don't often use that term in my practice because I find that PANS and Pandas is a smaller term than what we really are talking about. Autoimmune encephalitis is this big, PANS and Pandas is this big. So I understand PANS and Pandas, which is a pediatric illness, and it can have an acute presentation with the tics and all of that. But the issue is that these kids may not have a tic, or they may not have had an acute onset, they may have had a subacute onset, and so then you're stuck because you're out of the definition of what PANS and Pandas is. But in reality, they are having the same problem. It's just that it may be a different type of an autoimmune encephalopathy. And this is just I pulled that off from the Mayo Clinic website, and anybody can order this. Quest, my local lab, Northwell lab, you just call them and find out if they sent to Mayo Clinic for this panel, and usually they do. This is the Cunningham Panel, which is it's a specialty lab, and it runs specific. They have 4 antineuronal antibodies. It's a little bit more sensitive than some of the other testing for antineuronal antibodies that I talked about. And again, it focuses on PANS and Pandas, which is the pediatric presentation. But I think that adults that I've checked, who I suspected have an autoimmune encephalopathy, also came back positive for it. And PANS and Pandas, which is specifically for strep, I believe that it can be caused by other infections, including Lyme, Mycoplasma, Bartonella, and other parasites and yeast even. And this, I don't want to go into too much detail. I guess the main takeaway point from this slide is where they looked at brain PET scan, which is again one of those metabolism scans of the brain. And they showed that they've only been able to identify about 47%, or let's say 50% of the antineuronal antibodies when they suspected clinically and radiologically that a patient actually has autoimmune encephalitis. So my point is that we don't have all of the antineuronal antibodies that are out there. So if you suspect autoimmune encephalitis, but a patient's testing negative for these antibodies, it doesn't mean that they're lying or faking or you're doing something wrong. It means that the science hasn't caught up to it yet, because it is a new field. And in terms of treatment, so it is an individualized approach. I keep talking about it. I think Dr. Turnbull has been talking about it. It's not the one magic bullet that cures everybody and is appropriate for everyone. You have to really look at what infections you have. You have to be persistent. You have to look at the autoimmune component, especially if people are not getting better on mainstream treatment. And personally, I'm an allopathic physician, so I'm not against herbal medication. I just recommend that it will be used in conjunction with the antibiotic. And if a patient's not getting better within 6 months, we look at the autoimmune component and potentially introduce immunoglobulin treatments, which are a simplified version of what they are, is basically try to strengthen your immune system. By binding the antibodies that are attacking your brain or your nerve, and basically allowing your body to heal itself. So IVIG does not work after one time. Sometimes it does, but typically patients need to be on it for at least 7 to 9 months to start seeing significant results if we're dealing with a patient who has severe inflammation of their brain or their nerves. So I'm going to switch gears to finishing up, wrapping this up. I think I have a couple of minutes. And one of the things that I think is talked about, and maybe some of the vendors here, is also like using preventative medicine. So I have patients who come in and we get them better, and then they'll tell me, oh, I got a tick bite. Come on. I can't get you better if you keep getting reinfected. So then they'll say, oh, I have it from Ohio. The whole family comes, 6 people. And I said, well, you're paying so much money to see me. Can you please fence your lawn? Like, I know you have 40 acres, but you're not hanging out in the 40 acres. You know, fence the 1 acre where you and your family is usually hanging out. It's the best money you'll ever spend. So I urge you to do the same, okay, and spray your lawn and protect your pets, because the pets will bring in the ticks into the house. Okay, they need to be vaccinated, they need to be checked. Make sure that you're doing that, and also protect yourself. Okay, with using, I particularly advocate permethrin clothing, and with exposed areas you use repellents. They're natural repellents here. And you obviously need to reapply that, but you really, you're not going to get better if you keep getting a tick bite. You keep, insulting your immune system. That's what you're doing. And I joke around and I say, look, we're all one tick bite away from a psychiatric diagnosis. And I wholeheartedly believe that, because I think that people who come to my practice have not been bitten by one tick bite that gave them all this craziness. I think they've had recurrent re-exposure, and over time, your immune system can't take it anymore, and this is what we see. So again, this is, follow me on Instagram and Facebook, Dr. Elena Frid, and I actually also have a YouTube channel called Lyme Talk with Dr. Frid. I talk a little bit about all of this stuff, so if you want to hear more, there it is. And this is my kids. So this is my product, which is the insect repellent clothing. It's available online and here. And hold on. No, here. I have to plug them in. Hold on a second. Here we go.
What about Dr. Frid's kids wear, aka our mom's clothing?
Nice.
Yeah, she designed it for us because if a bug bits us or anything else, it would fall off and it won't affect you.